Good morning, everyone, and welcome to Cardiovascular Medicine Grand Rounds. This week, we are privileged to hear from one of our outstanding fellows, Dr. Attila Feher, who will be introduced by Dr. Al-Sanusis momentarily. Before I pass things over to Dr. Sanusis, just a few friendly reminders. You may feel free to enter any questions into the chat function anytime throughout the course of the talk. They will be answered at the conclusion of the talk. Alternatively, you can raise your hand at the end of the talk during the question and answer session. So thank you everyone for joining, and I will pass things over to Dr. Sanusis. Thank you.
Good morning. It's my pleasure to introduce Attila Feher, who obtained his MD degree at the University of Medicine in Hungary in 2007, and then went on to get a PhD in physiology at the same institution, completing those studies in 2012, and then did a 2-year research fellowship at the Georgia Health Science Center University in Augusta, where he studied, again, basic vascular physiology and a number of preclinical models of diabetes. Then he went on to do his residency in medicine at Cornell, which he completed in 2016, at which time he joined our fellowship, starting in the Yale Translational Research Imaging Center as a research fellow, where he spent 2 years. And he continued to evaluate coronary physiology, microcirculation, and a number of animal models, and then translated those quantitative approaches actually to clinical studies. Predominantly focused on PET imaging. His initial work was in the transplant population, although now he's working in rheumatologic diseases, looking at microcirculation. He has already co-authored 37 manuscripts and has won a number of awards. He won the Hungarian Physiology Society Research Award. He won the Japanese Society of Microcirculation Young Investigator Award. He won the Paul Dudley White International Scholar Award at the American Heart Association. He was a finalist in ASNIC's Young Investigator Competition, and he just received the Young Author Achievement Award for his publication in JACC Cardio-Oncology. So it's my pleasure to introduce Attila.
All right, let me share my screen. All right, I hope you can see my screen. So first, I would like to thank Dr. Sanusis for the kind introduction. And second, on behalf of all the graduating fellows, I would like to thank Dr. Velasquez, Dr. Miller, and Dr. Gandhi and really all the Yale cardiovascular attendings for providing us such a great training environment for the past 3 years. And during my talk, I will be talking about my prior work in the assessment of coronary microvascular function. I will start with some studies that I did before joining Yale, and then I will show some studies that I was able to accomplish at Yale. So this is the outline of my talk. Again, first I will start with some preclinical investigations that I did for the assessment of coronary microvascular disease in animal models and both and also in humans with obesity and aging. Then I will continue to talk about our data with the PET myocardial blood flow quantification with the evaluation of allograft vasculopathy. Then we'll show some of the data with quantitative coronary CT angiography in Doxorubicin-Induced cardiotoxicity models. And then finally, I will show some of the newer data that we obtained in patients with the Raynaud phenomenon and also in patients with autoimmune disease as regarding for PET myocardial blood flow quantification, showing the prognostic value of this in this patient population. And finally, I will show some new exciting results that we recently obtained on a new journey with digital blood flow assessment in patients with the Raynaud syndrome. So to start with the postdoctoral investigation, I really did my postdoctoral work working on isolated coronary arterioles. And I used discarded right atrial appendages of patients undergoing heart surgery or obtained from animal specimens. And I collected these tissues in the operating room. And then I isolated, dissected, and cannulated these tiny little vessels, which are 100 micrometer in diameter. So this is a very delicate procedure. It took me a long time to study with microsurgical instruments. You have to keep these vessels alive, and created a physiological setup. And if you apply drugs luminally to these vessels, you can see the diameter changes as the vessel constricts or the vessel dilates in response to these, and you can measure the diameters. As far as for the first, this is an example of these studies where you can see that the basic approach that I use is I applied vasodilators or vasoconstrictors such as acetylcholine, and you can see here on this graph that increasing doses of acetylcholine resulted in progressive vasodilatation in the isolated coronary arteriole. And in this instance, we used a rat model of obesity, and we did show that in obese models animal models of obesity, we see preserved vasodilatation, coronary vasodilatation, which is, in this instance, we showed that it was mediated by an iburotoxin sensitive large conductance potassium channel. So we were able to block the response with iburotoxin. Another project, which is again done in an animal model of obesity, high-fat, diet-fat rats, we did see that the bradykinin-induced responses were slightly elevated in this model, surprisingly. And we did show that when we looked at it, that there's increased local ACE activity in the endothelium, in the coronary vascular wall. So increased ACE activity can lead to either increased bradykinin-induced dilatation, and also acetylcholine-induced dilatation is preserved. So obesity has preserved dilatation or even improved dilatation. It's quite well known that gap junctions are present in cardiomyocytes, but it's lesser known that gap junction are actually present between endothelial cells and between smooth muscle cells within the vascular wall. And this helps with the propagation of the vasodilator response or vasoconstrictor response. And this has been shown in animals, in skeletal muscle arterioles before, but it was not shown in humans. And we came up with this I think, really nice setup where we isolated a very long coronary arteriole from right atrial appendages. It's a 1.5 millimeter length. We cannulated this vessel and put in a chamber where there's a continuous superfusion of the perfusate abluminally. So around the vessel, there's a continuous flow. And we applied a focal, very small amount of bradykinin focally. And we checked that the vasodilator response is locally and remotely at 500 micrometers and 1,000 micrometers away from the application site. And as you can see, we were able to express some dilation response locally and also remotely at 500 micrometers and 1,000 micrometers. And we were able to block these responses with the application of gap junction inhibitors. So this was really the first study to show this conducted vasodilatation in humans. Moreover, we also did show some differences when it came to young and old individuals. So coronary arterioles isolated from old individuals had preserved local response, as you can see, but there was a decrease in the remote responses at 500 micrometer and also at 1,000 micrometer. Also, another interesting question that we raised, it's known that the fat, the adipose tissue, is metabolically active, and it can produce vasoactive substances that can result, it can change the coronary behavior. But we had the idea, this what happens if we have the arterioles, the vessels inside the fat, and maybe these vessels, if you put them in a fat environment, these vessels may produce something that can impair the coronary vasomotion. So we created another interesting setup where we connected adipose tissue arterioles and coronary arterioles serially with a continuous slow flow throughout the system. And we assessed coronary responses within the system. And what we found is that when you compare to two coronary arterioles connected serially, those the coronaries that were connected to an adipose tissue arteriole had reduced bradykinin-induced dilatation, particularly when it was the fat arteriole was from an aged adipose tissue, an aged person. And we were able to block these reduction in coronary vasodilator response by applying multiple different blocking strategies for TNF-alpha. So what we think is what can happen in aged adipose tissue is that there's increased shedding of TNF-alpha to the system, and this soluble TNF-alpha can be released to the circulation and may impair dilatation in the coronary arterioles, especially related to aged adipose tissue. So this is probably give you an idea of what I was doing before doing my postdoctoral work, and then I did my residency in New York. And before, when I applied for fellowship, I was really looking for a spot where I could get a solid clinical training, but also could continue with my investigation of the coronary microcirculation. Hopefully, I will be able to show you that I was able to get some results regarding for this. So why to study the coronary microcirculation? It is known that at rest, approximately 85% of the oxygen is extracted by the myocardium, as therefore any kind of increase in oxygen demand needs to be met by increase in perfusion. So this can only be achieved by vasodilatation. And as you can see, most of the resistance lies in the coronary microcirculation. So the coronary microcirculation is really the gatekeeper for when it comes to increasing blood flow. It's also lesser known that most of the myocardial blood volume also lies in the microcirculation. And it's important to keep in mind that physiological parameters strongly affect both maximum hyperemia and baseline myocardial blood flow, such as heart rate, preload, afterload, contractility, and even anemia and hypoxemia can significantly affect baseline coronary flow. The coronary microvascular dysfunction can be grouped to 4 different categories based on Dr. Kimichi's 2007 New England Journal of Medicine review. And I will primarily going to talk about the 2 first categories: the primary coronary microvascular dysfunction in the absence of CAD, obstructive CAD, and myocardial diseases, and also microvascular dysfunction in the presence of myocardial diseases such as allograft vasculopathy and Doxorubicin-Induced cardiotoxicity. And throughout the years, it has been established that PET is the non-invasive gold standard of evaluation of coronary microvascular dysfunction in the absence of epicardial stenosis. So first, I would like to talk about cardiac allograft vasculopathy, which is a late occurring complication of heart transplant. It is associated with the diffuse concentric luminal epicardial narrowing, and also associated with diffuse microvascular disease, which is associated with stenotic wall thickening of the small vasculature. And when there is coronary microvascular dysfunction, it is always associated with worse outcomes. So we came up with a hypothesis for this study. It's not a hypothesis, but we wanted to investigate 2 things. with PET myocardial flow reserve in heart transplant population. And one was to assess the long-term predictive value of PET myocardial flow reserve. And also we wanted to see whether there's any role for serial assessment. So we have obtained the PET myocardial perfusion in 89 patients, 89 heart transplant patients. And approximately 2 years later, the 69 patient had a second PET study done. And these patients were followed up for 8.6 years. So quite long follow-up time, with the primary outcome being all-cause mortality. And what we found that during these 2 years, the rest myocardial blood flow increased non-significantly. The stress myocardial blood flow decreased non-significantly. And there was a significant decrease in the coronary flow reserve or myocardial flow reserve, which was significant over time. And interestingly, we also found that those patients with more rejection episodes had reduced coronary flow reserve when compared to those who did not have rejection episodes. This is the outcome data that we got. And here you can see that those patients with low myocardial flow reserve, with the cutoff being 1.5, this is rate pressure product corrected flow reserves. So those patients with, indicated by green, with low myocardial flow reserve had significantly worse survival when compared to those patients who had normal myocardial flow reserve, with normal being over 1.5. And as for the serial imaging data, you can see that those patients who had a reduction in myocardial flow reserve over time, so you can look at the blue curve here. So these patients who got reduced myocardial flow reserve over time, so they went from myocardial flow reserve above 1.5 to myocardial flow reserve below 1.5, they have similar survival when compared to the green curve, which had persistently low myocardial flow reserve. And conversely, those patients who improved their myocardial flow reserve from low to normal had very similar flow reserve compared to those who had persistently normal myocardial flow reserve. And we also did multivariate logistic regression analysis, and we did see that both myocardial flow reserve, but more importantly, delta myocardial flow reserve, so change in flow reserve over time, are both predictive of overall mortality in this patient population. So for the past 2 years, multiple publications have been published with regards to coronary flow reserve being predictive in the heart transplant patient population. And for example, this is from the Brigham, this is from the University of Michigan, and also this publication, I do believe, is from the Ottawa Heart Institute. So these all show that the PET myocardial blood flow quantification has a significant value in predicting adverse events in this patient population. So multiple high volume PET centers coming up with similar results. So this suggests that the signal that we were seeing might be true. And really our contribution to this whole picture is that the long-term predictive value of myocardial blood flow quantification, and also the serial imaging. As far as, so we summarized this data together with Dr. Sinus's in a recently published review article where we discussed the role of PET for the diagnosis of allograft vasculopathy. There's a good correlation with angiography, IVUS, and index of microcirculatory resistance. Also the prognostic value in predicting death, myocardial infarction, heart failure hospitalization, or heart retransplantation. And we also discussed the role of serial imaging and the emerging need for molecular imaging to be performed in this patient population. So the coronary microvascular disease is really an important clinical problem. Therefore, there is a big need for translatable preclinical studies to be performed. And I had really the pleasure to work at the Yale Translational Research Imaging Center for 2 years, where we have all these preclinical and clinical tools which we can use for the investigation of the coronary microcirculation. And the next study was done at Whiterick. And in this study, we were looking for investigating the coronary microvascular disease in Doxorubicin-Induced cardiotoxicity in an animal model of Doxorubicin-Induced cardiotoxicity. And we used serial imaging with serial coronary CT angiographies and transthoracic echo in these animals. And these animals received doxorubicin for 15 weeks, and by the end they developed doxorubicin-induced cardiotoxicity. And during each protocol, we did do coronary CTA at rest after adenosine administration or during adenosine administration. We repeated the rest with the rest 2, and we also did coronary CT angiography while administering dobutamine. And we measured the epicardial coronary artery diameters at preset distances from the coronary artery origins. Here's a representative figure of how it looks like at baseline and when after administration of adenosine. And with as you can see here, the rest 1 and rest 2 diameters the rest diameters were highly reproducible, and there was a good correlation between rest 1 and rest 2 diameters with an interclass correlation coefficient of 0.86. And also the blend Altman analysis showed that there was no significant bias between rest 1 and rest 2, and there was a good agreement between the 2 measurements, which suggests that this may be reproducible. And as you can see, by 12 weeks, the animals developed histological evidence of doxorubicin-induced cardiotoxicity. And by 12 milligram per kilogram cumulative dose, they also had reduced ejection fraction. But again, it's happened quite relatively late at 12 milligram per kilogram cumulative dose. At the same time, global longitudinal strain was impaired relatively early at 4 milligram per kilogram dose. And this was not surprising considering the available clinical data. I wanted to show this flowchart to explain a little bit better what we were looking for when measuring epicardial diameters in response to adenosine and dobutamine. So adenosine presumably causes epicardial vasodilatation by flow-dependent vasodilatation. And this is initiated by arteriolar smooth muscle cell A2 receptor activation and subsequent eNOS activation, leading to increase in flow and then flow-mediated vasodilatation in the epicardial vessels. Conversely, dobutamine primarily causes vasodilatation by myocardial beta-1 receptor activation, which leads to increase in metabolic activity, hypoxia, and tissue metabolites, which then lead to arterial vasodilatation and then subsequent flow-mediated dilatation. And there are some other pathways that are less important in the dobutamine-induced responses. So 2 different ways of causing vasodilatation. So interestingly, what we found is here the responses are grouped based on vessels, LAD, circumflex, and RCA. And if you focus on the first graph, you can see that the adenosine responses indicated by red got impaired relatively early during the process at 4 milligram per kilogram, whereas the dobutamine-induced responses happened at a later time point at 8 milligram per kilogram. But again, this is still before the 12 milligram per kilogram reduction. And this was true in all 3 vascular beds. And this summarizes the results. Again, adenosine-induced responses got impaired at around 4 milligram per kilogram doxorubicin dosing, similar to global longitudinal strain. And dobutamine responses get impaired around 8 milligram per kilogram cumulative dose. And this happens before impairment in the LV ejection fraction. So this suggests that coronary CT angiography may be used for the early prediction of doxorubicin-induced cardiotoxicity. So now I'm switching gears a little bit, and I would like to talk some about a new venue that I started to work on, this cardio-rheumatology. It is quite well known that autoimmune rheumatic diseases are independent risk factors for cardiovascular disease, and the cardiovascular disease lifetime risk is significantly higher in patients with rheumatoid arthritis, lupus, systemic sclerosis, and Sjögren's syndromes when compared to the general population. And on the right in this figure, you can see that it's not really well appreciated that patients with rheumatoid arthritis without diabetes have very similar cardiovascular risk compared to patients with diabetes, which is considered to be equivalent to a prior MI risk. So it's not insignificant risk. It's not an insignificant risk factor. And what is the underlying mechanism for this increased cardiovascular risk? It can be the increased frequency of traditional risk factors such as hypertension, diabetes, obesity, or smoking, or autoimmune rheumatic disease associated cardiac involvement, maybe systemic inflammation, or maybe related to side effects of medications such as steroids and cyclophosphamide. Also can be related to the sedentary lifestyle adopted by these patients due to arthritis or pain. And it's not insignificant to mention depression that can lead to increased cardiovascular risk. So during this year, together with Dr. Foreman, we started to develop a cardio-rheumatology program with close collaboration with rheumatology. And as you can see, this is really a multi-team approach. So the cardio-rheumatology patient is in the middle, and we'll all the specialists line together to provide the best possible care for the rheumatology patients. And our main focus is on primary prevention and also managing complex cases with autoimmune involvement. And we just started recently, but we already follow 137 patients. As you can see, the breakdown, most of patients have rheumatoid arthritis or systemic sclerosis, lupus, and some of them have Sjögren's syndrome. So we're really excited to have this program up and running. And how autoimmune conditions can involve the heart, it's really a wide variety of diseases that can be diastolic dysfunction, or it can be systolic dysfunction. There can be conduction defects, cardiac fibrosis, which is the hallmark of systemic sclerosis, pulmonary vasculopathy associated with pulmonary arterial hypertension, pericarditis, myocarditis, and there can be accelerated atherosclerotic disease leading to coronary artery disease. And most importantly, from my standpoint, they really have a higher risk for developing coronary microvascular disease. And interestingly, the coronary microvasculature is commonly affected by autoimmune rheumatic diseases. However, to date, there were no large PET myocardial flow reserve studies in this patient population. So, and it is unknown whether PET myocardial flow reserve can predict adverse events in this patient population. And this is a study from 2009 by Dr. Kamich's group, published in the European Heart Journal, showing in 25 patients that myocardial flow reserve was reduced when compared to controls, and there was a significant correlation between disease duration and coronary flow reserve. But again, this is a very small number of patients, a small patient cohort. I would like to talk a few words about Raynaud's phenomenon before I show our data that was obtained. The Raynaud's phenomenon was initially described by Maurice Raynaud in the 1860s, and it comes with very characteristic color changes when we expose the fingers of the patients to cold. And we can distinguish primary and secondary Raynaud syndrome, where primary Raynaud syndrome has no associated other diseases, whereas secondary Raynaud phenomenon has associated conditions such as autoimmune diseases. And this is the nail fold capillaroscopy images, representative images of primary and secondary renal, where you see the nice and symmetric, normal appearing nail fold capillaries and the big dilated tortuous capillary loops in the secondary renal phenomenon. And other than these, the different nail fold capillaries, secondary renal phenomenon patients are usually older at the age of onset. They more frequently have autoantibodies. They show frequently endothelial signs of endothelial damage, and they more commonly have digital gangrene. So we try to, it's not known whether there's an increased risk for coronary microvascular disease in patients with Raynaud's phenomenon. So we designed this retrospective cohort study, and we looked in our PET database to find patients who had Raynaud phenomenon and underwent PET myocardial blood flow quantification or PET myocardial perfusion imaging, and we find 49 patients who had this study, and 11 of them had primary Raynaud, 18 had systemic sclerosis, and 20 of them immune disease other than systemic sclerosis associated with the Raynaud's phenomenon. And initially, we wanted to compare these patients to healthy participants. So we have a normal database that was already done with 14 patients, healthy individuals who underwent PET myocardial perfusion imaging, just to establish a normal database for myocardial blood flow. And we initially wanted to compare the Raynaud patients to this patient population. However, the reviewers were very adamant to include a match patient cohort. So we went back and identified 49 patients who had no autoimmune disease and no Raynaud's phenomenon, and matched them with our Raynaud patient population. And we matched them for age, gender, BMI, and different comorbidities. And as you can see, the matching worked quite well. There was no significant difference with these parameters. So we find a matched patient cohort, and we also compared the results to healthy participants. And as you can see, there was a weak but significant correlation between the time since Raynaud diagnosis and myocardial flow reserve, and there was no significant correlation between sedimentation rate and CRP with myocardial flow reserve. And when it came to assessing the myocardial blood flow, as you can see, patients with secondary Raynaud phenomenon had significantly reduced stress myocardial blood flow when compared to healthy participants. And interestingly, our match control patient cohort had also had a reduced stress myocardial blood flow that was significant. At the same time, the rest myocardial blood flow was significantly higher in secondary Raynaud patients when compared to the match control group. And this led to impaired myocardial flow reserve, interestingly, only in the systemic sclerosis group, both when compared to the match controls and both when compared to the healthy participants. So reduced stress myocardial blood flow, increased rest myocardial blood flow, and reduced myocardial flow reserve. And we did a univariate analysis to identify predictors of reduced myocardial flow reserve in these Raynaud patients, and we used those who were significant, meaning equal or less than 0.10 for p-value in multivariate models, in addition to age and gender, and really only systemic sclerosis came out to be an independent predictor of reduced flow reserve. We used a cutoff of 2.0 in this instance. So that's good. We know that the Raynaud phenomenon, especially in systemic sclerosis, has reduced myocardial flow reserve, but we don't know whether this is prognostic in this patient population. So we took a relatively different approach with a larger cohort of patients with any kind of autoimmune rheumatic disease, and we identified 101 patients who underwent PET myocardial imaging, and we matched them with 101 patients without autoimmune rheumatic disease. And again, we performed a matching for the same parameters. And as you can see, there was no significant difference when it came to age, gender, BMI, race, or comorbidities. And as for the breakdown, you can see the most frequent diagnosis was rheumatoid arthritis, followed by lupus, scleroderma, and Sjögren's syndrome. On the left, you can see that stress myocardial blood flow was not significantly different in autoimmune rheumatic disease patients. The rest myocardial blood flow, however, is significantly higher in this patient group, which led to reduced myocardial flow reserve. So again, we saw very similar data with a different but similar patient population. The rest myocardial blood flow was elevated, leading to reduced myocardial flow reserve. There was, when it came to the different diagnoses, there was really no difference when it came to stress myocardial blood flow, rest blood flow, and myocardial flow reserve among the different autoimmune groups. And this is the survival data. This is unadjusted survival data. So for the combined endpoint of death, MI, or heart failure admission, as you can see, the patients with autoimmune disease with low flow reserve, and the cutoff is 1.5, indicated by green, had significantly lower worse survival when compared to patients with autoimmune disease but normal flow reserve, and also when compared to patients with no autoimmune disease and normal flow reserve. But there was no significant difference when compared to patients without autoimmune disease and low flow reserve. So, and we did adjusted survival analysis, and we adjusted for the non-laboratory based framing and risk score, which incorporates age, gender, and cardiovascular comorbidities and smoking in the assessment. Also, we adjusted for medium to large perfusion defects. We adjusted for severe coronary calcifications, and we made all these adjustments. The patients with autoimmune disease and low myocardial flow reserve had significantly worse survival when compared to all these patients groups. So even when compared to patients who had no autoimmune disease and low myocardial flow reserve. So, and next, what we did is we did a multivariate analysis to identify predictors of event-free survival for the combined endpoint. And we found that both myocardial flow reserve and autoimmune rheumatic disease diagnosis were independent predictors of the outcome, in addition to medium to large perfusion defects, and also in addition to congestive heart failure. So this was a very good finding for us. Again, I would like to go back to a little bit to talk a little bit about Raynaud's phenomenon again and digital ulceration. So in patients with systemic sclerosis, this is really a big problem affecting approximately 20 to 40% of these patients with severe digital vasculopathy, including digital ulcers, critical digital ischemia, gangrenes, or the need for digital sympathectomy. And approximately 15 to 20% of these patients have amputation of one or more digits secondary to ischemia, and approximately 9% of them even have multiple digital loss. So this is really a big morbidity problem in patients with systemic sclerosis. And unfortunately, the evaluation of hand perfusion is really limited. We can use semi-quantitative methods, just like digital tomography, to assess for temperature of the skin. And as you can see, this hand shows maybe lower temperature, suggesting of reduced hand perfusion. We can also do capillaroscopy to check for those dilated vascular loops, but there's really no good tool to assess hand perfusion. And importantly, there are really no good predictive tools to predict digital ischemic loss. Maybe some anti-centromere antibodies or current smoking and some other antibodies are more predictive of having digital ischemic loss, but we don't have a really good solid predictive tool that we could use to intensify therapy in patients with Raynaud. Recently, Dr. Sinusas and his group published a this nice paper evaluating the prognostic value of radiotracer-based perfusion imaging in patients with critical limb ischemia. And as you can see on the right, there were individuals who responded really well with perfusion to revascularization, and there were poor responders whose perfusion did not improve much. And interestingly, those patients who have improvement in perfusion had significantly better amputation-free survival when compared to those patients who did not respond that well. So this project gave us an idea that maybe we could look at quantitative blood flow analysis in the hands and to see whether that could be predictive of outcomes in renal patients. So this project is really in baby steps. We just acquired 5 healthy individuals and we did rubidium PET with dynamic image acquisition in 5 patients with multiple hand positions. And as you can see, there was a signal, rubidium signal in the hands. And with the help of this software, I was able to segment the hands. And if you segment the hands and check the tracer uptake over time, you will see that this is a nice input function from the ascending aorta. You can see the peak in the aorta and coming down, and I'm hopeful that you can appreciate it. That this is a nice nice signal, rubidium signal obtained from the hands that is substantially higher than the background activity that is indicated by purple over here. So if you apply kinetic modeling, you can estimate hand blood flow in these patients. So we did multiple acquisitions, and this is just 3 patients where we did right hand imaging on the right side of the chest and right hand on the left side of the chest. And I hope that you appreciated that the results, the flow that we got seems very reproducible when we repeat the measurements, which is very promising. Of course, we will have to do more studies. We have to do more healthy participants. We have to see what happens with stress, and we also have to see what happens in renal patients, whether there's any difference. But I think these are some exciting new data that we will continue to work on. So as a conclusion, I hope I was able to show you that preclinical and translational investigations are really important to make advances in the diagnosis and the treatment of coronary microvascular disease. There is emerging data about the use of PET for the non-invasive diagnosis and for the prognostication of allograft vasculopathy. And I hope I was able to demonstrate some role for serial imaging in this patient population. I also show that coronary CTA can reliably assess epicardial coronary diameters in response to pharmacological stressors, and that non-invasive functional index of coronary reactivity can be used for this tool, for this. And also impaired epicardial vasodilatation, particularly to adenosine, happens early in the process of doxorubicin, in the process of development of doxorubicin-induced cardiotoxicity. As far as for Raynaud's phenomenon, we showed that primary Raynaud is associated with preserved myocardial flow reserve, whereas systemic sclerosis associated, Raynaud is associated with reduced flow reserve, both when compared to healthy participants and matched controls. And systemic sclerosis is the only independent predictor of reduced flow reserve, at least in our population. Also, we showed that autoimmune rheumatic disease patients have significantly reduced flow reserve when compared to matched patients without ARD, and both ARD diagnosis and decreased myocardial flow reserve are able to predict adverse events in these patients. And also, I shared some new exciting data about digital blood flow assessment by rubidium PET, which may be able to provide a quantitative tool for the assessment of Raynaud phenomenon severity. And we will test this for the prediction of adverse events, adverse digital outcomes. So as far as for future directions, I'm really hoping that I will be able to continue to develop the Yale Cardio-Rheumatology program together with Dr. Furman and Dr. Hinchcliffe for the integration of clinical care and also integrating clinical and translational research to develop a strong program at Yale. And I'm hoping to translate our preclinical findings to humans. And really, there's a huge need, unmet need for prospective studies to assess whether PEP flow reserve can be used to monitor therapy and also whether it could be used for drug discovery for the treatment of microvascular disease. And that there is a really urgent need for developing molecular imaging strategies to evaluate the coronary microcirculation. So with all these, I would like to thank mostly my mentors, Dr. Sinusas, Dr. Hinchcliffe, Dr. Miller, and Dr. Furman, and my prior PhD mentor, Dr. Buggy, for all the help and really all the other people who helped me to get these studies finished. And it's really an incomplete list. So there are a lot of people who helped me to work on these projects. With this, thank you for your attention, and I'm happy to take any questions and answer any.
Attila, thank you very much. That was an incredibly impressive body of work. Really tremendous. At this point, can take any questions. Can you either raise your hand or type questions into the chat function.
Dan, maybe I can go first. Attila, wonderful job and you know, really a comprehensive review of your efforts over really a decade. So thank you for sharing that. I wanted to go back and try to make a few connections from and through some of the themes that you've outlined, you know, from your postdoctoral work to now. And as it relates to the rheumatological diseases, there has been a tendency, and I think a transition from prednisone, I guess, and other steroidal approaches to disease-modifying agents. And when you talked about the vessel-to-vessel connections you did in your microsurgical experiments, it got me thinking that there may be something about how we treat patients that changes their adipose tissue or what have you that could have an impact on the microcirculation. So I'm curious if you've explored that intersection about how the treatment choices may in fact relate to microcirculatory changes over time.
Yes, I think that's a really interesting and very important question. I'm not aware of any studies that investigated, but it would be a really good idea to look into that. And we certainly have the tools to look at it. We have a strong room program with a lot of patients, and we have the clinical tools to assess this. So I think it's a good idea that could be explored further down.
I think Barry had his hand raised first for the next question.
Yes, thank you, Attila. A wonderful body of work and a very wonderful talk. I have two mechanistic questions for you. As one compares the data in the rheumatologic patients with other cohorts, in the rheumatologic patients, you're developing a flow reserve measurement based on an increased resting flow. And the abnormality that you see may not be due to failure to recruit appropriate vessels in a flow response, but may depend upon the resting flow. So I'm not sure it's fair to use the same flow reserve measurement, and we may be dealing with something comparable to systolic or diastolic heart failure. So that's question number one. Question number two relates to doxorubicin. And over the decades, there have been any number of mechanisms proposed based upon preclinical models and free radical has been a major one, other metabolic changes. And do you think that doxorubicin-induced flow reserve decrements are primary, or may they be an epiphenomenon associated with another mechanism?
Mm-hmm. Yeah, those are really great questions. Thank you for asking those questions, Dr. Zaher. So let me go back and share my screen because I might be able to better answer the questions. And I want to go back to one of the slides here when it comes to the first question with the resting flow. And I wanted to, okay, it was here. So it was this slide. So I agree with you. It seems like the signal that we're seeing in both of these studies is the increased resting flow. And we were sort of puzzled with this. And when I looked into the literature, I found some interesting studies, and I will try to look into this to include even a larger database, like looking at all our flow data. Is that it's showing that actually an increased resting flow is also predictive of outcomes. So when it comes to flow reserve, it's not really all about the impaired hyperemia that is showing some sort of adverse signal that something is happening in the microcirculation, and but resting flow might be also important. And we were a little puzzled, like, why is the resting flow increased? And we were going through, at least I was going through this table to find ideas, and a few things that stuck out is one of that is sympathetic activation, and these patients, the autoimmune patients, are known to have autonomic nervous dysfunction. So there might be some increased sympathetic activation that is driving this. And also the other hypothesis that we came up with is that there might be some increased microvascular resistance at baseline, and the heart is just trying to compensate with increasing the flow to overcome this increased resistance. And maybe that is one of the mechanisms. As regarding to your second questions, we don't really have any good insight whether this is a primary microvascular dysfunction versus a secondary. But it's interesting because the doxorubicin, how doxorubicin gets into the cardiomyocyte, it has to go through the endothelium. So the endothelium is really the first line which is seeing the doxorubicin effect, and for that reason, it might be a primary endothelial dysfunction caused by doxorubicin.
Thanks. I believe Jeff had his hand raised next, and then Arya after that.
Attila, wonderful work. Just actually an incredible body of work for where you are in your career at this point. So congratulations to that. All the questions you've heard already, including mine, are sort of dancing around the question of mechanism. And I wondered if you had any idea or could speculate about why this might have a preference. These abnormalities might have a preference for the microcirculation. I mean, I'm not sure that's absolutely true. There are some older studies in the RA population that FMD, flow-mediated dilation, which may be looking both at larger and smaller vessels, is abnormal in RA patients and actually improves with TNF blockers, which is, I think, fascinating over a period of 8 to 12 weeks. But I wondered if you had any thoughts or speculation about the microvessel preference for these abnormalities.
I'm not exactly sure what defines these. And as you're aware, we put these all these disease entities into one umbrella term, autoimmune disease, but it's really a basket of diseases, and one has more preference than the other. Like rheumatoid arthritis and lupus has been shown to be associated with strongly associated with the epicardial disease, versus scleroderma not so much. It's questionable whether it increases the risk of atherosclerosis. So I think it's really everything lies within the primary mechanism, how it gets the interaction with the endothelium, and like whether it interacts with fibrosis, whether it's driven by the sort of inflammation. So I'm not sure whether that answered, but I don't think the answer is really no.
Well, obviously the large and small vessels are lined by endothelium. So for those diseases that do have a microvascular preference, I wonder if are there any clues as to why that might be the case?
Mm-hmm. I'm not sure. I'm not sure about that.
Oh yeah.
First of all, very nice talk. I really enjoyed your talk. That very scientific aspects to it, and very also translational. So one question is actually not related to myocardial blood flow, and I apologize for that. But in your postdoc time, when you were studying the left atrial appendage arteries, and you use them as a microvessels, microvasculature, is that only physiological response that are abnormal, or did you see anatomical such as equivalent of what we see in atheromas, kind of macrophage infiltration, anything like that? Is there also present? Because not much is known about microvascular disease. And the second is that, do you see any heritability such as if you have isolated, let's say, microvascular disease, that one can actually study genetically?
Mm-hmm. Yeah, those are excellent questions. Let me answer the second one, that I'm not aware of whether there is of any inheritable course, but I'm sure there should be some, but I'm not aware of any investigation looking into that. And as far as for the first question for anatomical abnormalities, we were not particularly looking for those, but we were assessing. We did some electron microscopy examination of these tissues, and as you can imagine, these patients are undergoing heart surgery, open heart surgery. So these are not normal tissues. You can see that some of them, especially when you compare patients who just underwent AVR versus those who underwent CABG. Those patients who underwent CABG, they have really a destroyed, or mitral valve replacement, for instance, a destroyed atrial architecture. So there are some changes, but we did not particularly look into like what is the immune cell infiltration and other things.
Thank you.
All right, well, if there's no further questions, again, I'll thank Attila for an absolutely wonderful talk, and thanks to the section for joining us again. Next week, we'll have undoubtedly a terrific talk from another one of our star fellows, Catherine Clark. So thanks everyone for joining, and we'll